Good evening, everybody, and welcome all to the Asian Geriatric Oncology Society webinar series uh, number 8. We have been discussing on various topics throughout these 7 webinars before, and today we have with us Dr. Suzanne Festen, who's from Netherlands, and she's going to be talking about her experiences, the role of patient preferences in oncological treatment decision making. So, without further delay, I'll welcome Dr. Suzanne. Welcome.
Thank you very much. I will share my presentation. Oh.
We can see your presentation now.
You can see it? You can see it in also in presentation mode?
Right.
Great.
Yes,
Thank you.
yes.
Yes, well, thank you for the introduction and for the invitation. Very nice to be able to talk here to you tonight for you and this afternoon for me about the role of patient preferences in oncological treatment decision making, which is a topic for me, a research topic, but also something in clinical practice. I'm an internist geriatrician from the Netherlands, and I thought I'd give you some photos here of the University Medical Center Groningen, where I work in the northern part of the Netherlands. And well, as you can see in the picture below, it's cold here in winter. No snow, though. I had nothing to declare besides different cultural backgrounds, which I think is for this topic important and also interesting. So I'm looking forward to talk about this also later in the Q&A. Just a moment, I have to close my window here. Yes, so patient preferences is an important step, or the elicitation of patient preferences is an important step in shared decision making. And to start with this, if you look at decision making, there's different models of decision making. The paternalistic model, where well, the doctor is the one giving information and recommendation and making the decision for the patient. Then you have the informed medical decision making, where you provide the patient with information and let them make the decision themselves or together with their family. And then you have shared decision making, and shared decision making is a dialogue where you give information and you can also give recommendations. But an important aspect of this is elicitation of the values and preferences of patients. So what is important to them in their lives, and how can you align the treatment to what matters to the patient most? So this is what I want to talk about. And I would like to show you this model. This is the integrated oncological treatment decision-making model that we are using in Groningen and in the Netherlands to see what information components do you need to do shared decision making and come to an individualized treatment plan for your older patients. And as you can see, of course, you need the information about the disease and the treatment options, the state-of-the-art treatment options, with the advantages and disadvantages, but also with the treatment alternatives, because often we have one best treatment option, best for the disease, but there are also alternatives, maybe with lesser outcome, but sometimes maybe more fitting for this patient, or more aligned with their preferences. Then you have, of course, general health status, and if you look at older patients, then we do a comprehensive geriatric assessment or a geriatric assessment to have an idea about level of frailty, resilience, looking at the different domains. And the third component is the priorities. What matters to a patient? What are their goals and preferences? So in our hospital, we try to get all these components before we make a decision. And nurses play an important role in also getting this information, especially since nurses often have a different relation with the patient. This is a publication from 2021 about decision-making in older adults with cancer. And I just wanted to show you, because I think it's this is more and more also, if you look at in guidelines, also about preoperative decision-making for older patients, the things we look at, and it's aligns with what I just showed you. You need to have a geriatric assessment, have an idea about the prognosis of this patient, depending on age and comorbidities, balance treatment benefits and harms, and then consider the patient preferences and the trade-offs that the patient make, and then decide on your treatment. So I know we're in Zoom, and I don't know if it's possible to put your camera on so I can see at least a couple of you. And I just want to, I know summer and winter is of course also different here than there, but if I just want to do a little a discrete choice experiment, and I would like to ask you to raise your hand if you, between summer and winter, if you prefer winter. Okay, thank you. Can keep your hand up, and then we go to the next slide. So what if it would be summer alone and winter together? Can you raise your hand if you would prefer winter together? And I can only see a few of you, but I think this slide tries to tell you is that context matters, right? You can make a decision based on one item that can be different if you have to weigh the context. And here, when I do this here, then often most people choose summer because they like summer, because our winters are rainy and cold. But if the decision is summer alone, then more people choose winter. And so the context matters and the trade-off matters. So talking about preferences is shifting the focus of your conversation to what's important to someone and what trade-offs do they make. And this is an image about surgery, but I think it's a beautiful image from Niyama. And the questions that patients might ask themselves, and maybe they don't always ask them aloud to their doctors. What is the impact of a treatment on their lives? So if you look at patient goals and preference in decision making, the question is what matters most in a patient's life? What are the trade-offs they make? What are they willing to give up? What drives their choice? What is below the surface? And do they fully understand the choice? And talking about these trade-offs sometimes also makes it clear whether they do. And this is a quote from Terry Fried, who's been doing a lot of research also on this topic, and saying when treatment involves trade-offs, the best option depends on the patient preferences. And I think this is true. You can talk about preferences in many different forms. And here in the Netherlands, in Groningen, we started using the outcome prioritization tool, and this has been used in the Netherlands and also outside. This conversation aid was developed by Terry Fried, and it uses 4 universal health outcomes: extending life, maintaining independence, reducing pain, and reducing other symptoms. And patients are asked to rate each treatment goal on a scale of 0 to 100 in order of importance. The numbers don't have to add up. It's just a measure of the level of importance of each goal. But they are asked to put them in an order. So they cannot put everything on 100. And this is a start. We use this as a starting point of a conversation. So if a patient would use the tool and put it like in this image with maintaining independence as the highest priority, then the question would be, so what do you consider independence? What's important to you? What are you willing to give up? What if you need more home care? What if you cannot stay at home? Where is the trade-off for you? Because for some people, this means they would like treatment, but not if it means they end up in a nursing home. But this morning, I talked to a very old man, and for him, it was most important that he could take care of his chicken because he was breeding chickens, and this was the thing that was most important to him in his life. So it can be very different. So this is the start of a conversation, and we use the outcomes to see how can we align the treatment to what matters to a patient, and then discuss this when we do shared decision making. So the focus shifts from the treatment options and the percentages, if you look at the disease, to what is the impact of the treatment on daily life. And I don't know if you scanned the QR code here, but we had made a little animation movie about the outcome prioritization goal and how we use it. But this is just an example, right? It's not that everyone has to use this or this is the gold standard. It's just if you want to mark this conversation, I find that this helps, but there are many other ways to do this. And we did some studies on this, on the goals, the prioritization by patients using the OPT. And we saw that most patients, all the patients, prioritize quality of life or remaining independence. And this is the similar to the this study from Nelleke Segers, where she looked at studies done on patient priorities. And as you can see, there's not that many studies yet. And what she found is that most patients value quality of life as most important outcome measure, but not all. There are, of course, also older patients who prioritize life extension or survival. So it's important to discuss it and don't make assumptions about what someone finds important. So talking about preference is a way to look at more patient-centered outcomes. And there's, of course, often also if you look in literature, there is a lot of information about disease outcomes, about survival, about complications. But what we also want to know is what does a treatment mean for functionality, for instance, cognition, physical function? And this study was also shown at the last SCIO meeting about time toxicity, which I thought was also interesting. What does a treatment mean for time, a patient's time? And if you have limited time when you're older, the amount of visits and amount of stay in a hospital versus staying at home can also be a very important outcome measure. Like I said, it is important to ask explicitly because we know that preference misdiagnoses are frequent. If we assume what a patient would finds most important, we're often wrong. We might as well flip a coin. We see that from multiple studies, also a study we did here ourselves. And in a recent scoping review, we see that in shared decision making, the elicitation of personal perspectives is at a very low level still. So what's the difference if you between what we do now and patient-centered communication? It's where do you start? So do you start with telling what is the disease, what are the treatment options, and focus on the disease, or do you start with introducing the fact that there is in fact a choice and what is important to this patient and how do the different options align with the preferences? And this is also, I think, an interesting also website to visit, the best case, worst case scenario, where you describe different options and tell a story. So use a narrative to tell a patient what a treatment would mean. What's the best case, what's the worst case, and what's the most likely for this patient with this level of frailty, with these comorbidities. There's also this publication in the Journal of Geriatric Oncology, making it more, giving more insight in this best case, worst case scenario for cancer treatment options. As you can see here, for instance, someone with small lung cancer, how would the best case, worst case scenario work? I think this is also very interesting. And then, of course, the role of caregivers. They play a role for most patients, of course, in decision making, and the legal role varies from country to country. But they are very important, I think, in decision making, shared decision making, being a sparring partner, helping to retain information. But they also have their preferences, of course. And what I find that is talking with a patient when a family member is there about preferences also can give insight to the family. And often this conversation continues when they leave the hospital and go home. And it can also help align these different preferences that we sometimes see between patients and their families. At the last psych meeting in Montreal, I don't know who of you went there, but I thought it was interesting that there is more and more patient participation is being viewed as more and more important. And this Spark initiative was for the first time with all patient advocates, but all sort of policymakers, researchers, healthcare providers talking about what's important. So I thought that's an interesting development. And they showed these websites, which I think are interesting. The patient priority care, if it comes to preference elicitation, has a lot of information also for healthcare providers. And the Conversation Project, which is more focused on patients. So to come to my take-home message, patient preference and trade-offs are, I think, very important for personalized care and shared decision making, putting the focus on the impact of treatment on daily life and not just on the pros and cons of the treatment on the disease, which is often very difficult for patients to understand and oversee. But most patients, they know what they find important in their daily life. So it shifts your conversation. The patient perspective can, of course, differ from the perspective of the healthcare professional, which can sometimes also make it difficult. And it can also differ from the perspective of the family member. And it is important to ask this explicitly and align the treatment accordingly. Thank you for your attention.
Prem?
Shall I
Thank you.
unshare?
Yes, please.
Yes, just.
So thank you, Dr. Suzanne. I mean, for two things, it was a wonderful presentation, and you actually have saved us 2 minutes as well. So you're very much on time. So we can
Good.
obviously have more conversation as well. So I would still want to maybe start with the case, and then we will take questions later. So I welcome.
Can I just put a comment
Sure,
here?
sir. Sure, sir. Quick comment.
Suzanne, that is very good about how you have outlined what is the patient preference and how do we take into consideration. I would like to share with you just our experience. We asked the patients to give priority to one of six topics. The first one was best chance of cure. The second one was longest overall survival. And I think these are the two where doctors also focus. The third one that doctors focus is participation in a clinical trial. But the other three options that we wanted the patients to select, and about 21% of them selected these options, are least out-of-pocket expenses, least visits to the hospital, and least side effects. That is best quality of life. So I thought that I would share that with you.
Thank you. Yes, interesting.
Prem, over to you.
Especially from the Indian context, I feel that was a very important thing to highlight. I mean, a lot of times, I mean, we have talked about it just before I go into the case, that a lot of times patient preference doesn't come because the patient doesn't know. So that is another thing which is quite common in India. Okay, so welcoming all to the case presentation. I have Dr. Suzanne, of course, going to be a part of it. Dr. Steve Paul Manjali, who's a geriatrician from Bangalore. Then Dr. Bala Stalin Chaudhary, who is from Vizag. Dr. Aditya Murli could not join us because he had some local event. So I'm just going to go into the case. And thank you, Suzanne, for the case. I thought it would be nice to have a case with an international perspective. So the overview of the case: 75-year-old woman who had progressive dysphagia over 3 to 4 months, intermittent epigastric pain, pressure, occasional regurgitation with meals, increasing difficulty with solids, foods, and is eating mostly a soft diet as of now. Now she had difficulty in swallowing pills and has been crushing her medication. Now she had around a 15 lb weight loss, which is approximately around 6.8, 6 to 7 kg weight loss uh, over the last 2 months. Now, if we see her history of present illness, she basically has a progressive dysphagia. 1 minute. Yeah, she has a progressive dysphagia with gastric pain and pressure, occasional regurgitation, tolerating soft foods and liquids, slowly crushing medications. Now, past medical history, which I think is one of the very important things in geriatrics, as you can see, is a huge list. So she had anxiety, depression, she has type 2 diabetes, she has coronary artery disease, she has heart failure with uh, an LVF of around 50 to 55%, then preserved ejection fraction, of course, then chronic kidney disease, stage 2, fibromyalgia, hypertension, irritable bowel syndrome, GERD, microcytic anemia, obesity, osteoarthritis, gout, and even an endometrial adenocarcinoma of the uterus. So welcome to a lot of times. This could be the typical way an older person might actually present. So this is multimorbidity in the past, and of course having a current cancer as well. Past surgical history showed total abdominal hysterectomy and salpingo-oophorectomy in 2010. Now, one of the most important things which is there as far as the social history is concerned was she was a retired secretary, worked in hospital administration, lives alone with a cat. And is that Suzanne? Is that the distance from the
Sorry.
hospital?
Yes,
Okay.
kilometers.
Yeah,
Sorry.
that's fine. That's
Yeah.
45 kilometers from the hospital. Then fully independent with her ADLs, even drives short distances, does not exercise, has a penchant for gardening, ECOG performance status of 1, drinks red wine around 1 to 2 glasses Friday, Saturday, and former smoker, 30 per year, quit almost around 30 packs, quick almost around 2005. So it's been a while. Now, list of medications: omeprazole, amitriptyline, then aspirin, atorvastatin, clopidogrel, duloxetine, losartan, metformin, XR, metoprolol, succinate, and torsemide. So having multimorbidity with uh, polypharmacy also to an extent, of course, a lot of it might be essential. So the barium swallow, of course, showed the segmental narrowing of the distal esophageal extending to the gastroesophageal junction, which was suspicious for malignancy, and endoscopic correlation was warranty. Now, before I go further, I will just want to involve Dr. Steve here. So, Dr. Steve.
Yes, Dr. Prem, tell me.
Yeah, so I mean, you see this beautiful slide, which is not beautiful in any way, that where you have so much of multimorbidity along with, of course, the older person living alone still active. So I mean, is this something which you actually see pretty commonly, and is obviously, I mean, I can call it as a geriatrician's bread butter, but it sort of makes treating the cancer in that particular person not much that easier. So your comments.
Oh, so okay. So the first question is the patient aware of a likely diagnosis of malignancy there? Has that evaluation happened and has he been informed?
Yeah, I think Dr. Steve is saying, is the patient aware of her illness? Yes, yes, yeah.
All right. Yeah, so this is a very common scenario. I think all our patients would have at least a list of 20, 30 diagnoses at the time of presentation. And her interests have to be met. And at this point, we have a certain list of medications that need to be flagged down. And when and apprise her of the possible diagnoses and evaluation strategies that you would take.
Okay.
Is that what you're trying to say, Prem? Yeah.
Yeah. So as far as the barium swallow, which I mentioned, endoscopy correlation was recommended. So a CT abdomen pelvis was done. So there is a circumferential thickening of the distal of the esophagus around 6.3 centimeter, no pulmonary nodules, and mild cardiomegaly. So upper endoscopy and biopsy showed a fungating and ulcerative mass with stigmata of recent bleeding in the lower third of the esophagus, causing partial obstruction. And biopsy showed at 24 centimeters showed adenocarcinoma bucinous and signet ring features, moderately differentiated, stable, HER2 negative, and PDL140. So Stalin, Dr. Stalin.
Hello. Yeah, tell me.
Yeah, hi. First of all,
Hi.
welcome. And yeah,
Yeah, thank you.
I just wanted your comments on what would you want to do further at this particular moment that we have obviously discovered with the endoscopic and with the endoscopic
Yeah,
esophageal biopsy. Yeah.
yeah. It was the upper GI endoscopy was done, and it was confirmative of adenocarcinoma. So preferably we do a staging workup at this point of time. So ideal staging
Okay.
workup we do at our institute, or majority of institutes, is the PET CT scan. So we go ahead with PET CT scan and assess the disease status. So whether it is a localized or locally advanced or a metastatic disease, and plan treatment based upon that.
Okay. And with such a extensive history of multiple morbidity
Yeah.
and with previous cancer also, would that change your approach to this particular patient, or would you still want to go the same route?
Go same route, because I need to, at least for the prognostication part or the treatment planning part, to discuss at least the treatment planning part. So I need a staging workup. So ideally,
Sure.
I will do a PET CT scan. So establish the stage of the disease. Then based upon the polypharmacy the patient had, multiple comorbidities the patient had, I will plan the treatment.
Okay, so of course this was taken up in the MTT. So treatment options. So I mean, I have to get uh, Dr. Bala in here. Is she a surgical candidate and willing to consider surgery? Is she willing to get a feeding tube? Who is going to support her during this? And alternative options, radiation therapy. I mean, you can answer the first question, then I will obviously go to Suzanne and she can help me out with the second
Possibly,
part.
yeah, possibly by seeing all the comorbidities and the polypharmacy and the age, so she seems not to be a surgical candidate at this. And I think the nutritional status is fine, because in the esophagus and the esophagogastric junction cancers, the most important thing is, so in Indian context, delayed presentation can lead to the impaired nutritional status, so that they may not tolerate it. I assess the basic nutritional status of the patients, then can take a call. But by seeing this polypharmacy, multiple medications she is using, multiple comorbidities, may not be a surgical candidate for an extensive surgery which a gastroesophageal junction cancer patient needs.
Okay. So yeah, Dr. Suzanne, I would want to get you in with the next two parts. So is she willing for a feeding tube? And she only lives with a cat. So who is going to be a support her during this?
Yeah, I think the interesting question is if you look at all the information on the slides about this patient, then there's of course, if you look at it from a geriatrician point of view, then of course you look at the comorbidity, the polypharmacy. There's red flags there. There's also red flags in our history. She lives far away, which makes it difficult to come to the hospital. Well, I think that's nicely with the what was just told about patient preferences and finances, and also travel time being in a hospital. the interesting is that if you look at her performance score, there was 1, right? So I think that's a nice illustration of that this is not a good measure of frailty. And I think this is a patient with frailty, but of course, if we go back to my presentation just now, I think it's important also to talk to her about what her preferences are. What does she find important in life? And the fact that she lives alone with a cat, of course, doesn't tell us much about the network that she has around her. Even if you live alone, you can still have a network. So I think the patient preferences here are important to discuss. And but I think I would, if you just would ask me from a medical point of view, then I would have, I would wonder if surgery is a good option. I would have big doubts about that, and of course discuss it with the patient. But it's good to know what is important to her, that she is the most important to her life extension. And we might have a different discussion about this than if she would say, no, I would just like to be able to live with my cat as long as possible, to be able to eat normal as long as possible. And this would influence your, I think, your choices.
Okay. Yeah. So Dr. Bala, again, so alternative options, what about radiation therapy?
Yeah, definitely. If we are not going to do surgery for a gastroesophageal junction adenocarcinoma, our intent is palliative. We need to explain to the patient that so we are not going to cure this. Whatever the treatment modality we are offering to the patient is palliation. So one of the best forms of palliation to relieve the dysphagia immediately and the symptoms patient had is the radiotherapy. And at any point of age, majority of the patients may tolerate the palliative doses of radiotherapy. That's not a problem. So we can put a feeding tube so that the nutrition will not be impaired immediately, because radiation itself can cause toxicities and toxicities will take time to heal. So, so we put a range tube, feed the patient, deliver the palliative RT. So within a span of 20 to 25 days, possibly the dysphagia slowly comes down and patient can take orals. And
Okay.
RT radiation therapy is possibly a better treatment option if you are not going to do surgery for this patient.
Okay. Okay. Quickly before I go to the next slide, Dr. Steve. So nutrition is something, of course, which would be one of the top priorities in her.
I suppose so, considering she's living alone, and she's very particular about the way she lives. Nutrition is of paramount importance. But I had a question. Among the details that were shown, do we have any information on her cognition? Is she capable enough to take a decision? Is she cognitively impaired? All those, I mean, if there is a cognitive impairment, alters the whole picture. So in such a case, who would be the one taking a decision for her? Is there any relative or anyone else who can help in such a situation?
Okay, that's a pertinent question. So Suzanne, I mean, did she actually have, I mean, anybody else?
No, this was also my question. This was a case we discussed at a SIOC meeting. So it
Okay.
is not a case, not a patient that I saw. And
Okay.
I think this is a very important question, of course. How is she cognitively? Is she able to make a decision? And if not, who can make the decision for her? I put this slide in also because this is
Yeah,
the
I mean,
steps.
you can comment on it because you can comment on it. Yeah.
Thank you. These are the steps that we use in our Oncogeriatric MDT in Groningen. Just I thought it might be nice to give an idea how we would discuss this patient if we would see her here in the Netherlands. And we try to, of course, look at the treatment, life expectancy of this patient with and without the disease and with and without treatment. Are there complaints that would be resolved? Of course, she has difficulty swallowing, so I agree that nutrition is very important also for her to be able to remain independent, if that would be her main priority. The burden of the treatment, she lives far away from the hospital, so also with radiation therapy, she would have to come to the hospital multiple times, of course. How is she going to manage that? Alternative treatment options, and of course the goals and preferences and expectations. So just to show you how we would do an oncogeriatric MDT, I put this slide in.
Yeah, I think it's a very focused stepwise approach, and thanks for this slide. So of course, she obviously has the cancer in the G junction, which we talked about, and surgically, of course, if it is removed, then obviously the esophagus will be joined to the stomach. Okay, so what about evaluation for esophagectomy? So important considerations, of course, are the rerouting, anatomy, and the high morbidity. So yeah, Dr. Bala, again, I mean, I would want your quick comment on whether, I mean, if she obviously goes for surgery, then what would be the bigger, I mean, what would be the changes which would happen for
I think
her?
the bigger challenge in the esophagectomy is the post-operative complication rate and the post-operative recovery period. So if you
Yeah.
in gastroesophageal junction adenocarcinoma, so if you are doing surgery alone, we know that it is not curative because patient needs an adjuvant chemotherapy and total completion of the treatment protocol so as she should be completely cured of the disease. So if the patient is receiving only surgery and we are not able to give chemotherapy, or if at all needed, if you are a patient, we are not able to give radiotherapy, ultimately she will have a higher chances of recurrences. So our surgical attempt may become futile. So at the initial diagnosis, we should plan in such a way that if I'm going to do surgery for this patient, whether she will be able to receive the post-operative treatment. If she is unable to complete the complete plan of the treatment of surgery, post-operative treatment, our surgical attempt may be futile. So right from the beginning, in the MDT itself, we need to discuss all these options. The major challenge will be the post-operative recovery because the post-operative complications, recovery period still impairs the nutritional status of the patient. It may sometimes cripple the patient also.
Okay, so I think yeah, recovery is long. Leaks can happen, prolonged recovery, sometimes months. Then possibility of readmissions, which Dr. Bala already talked about, maybe repeated EGDs, even stents. Then support system, of course, becomes very important here, which obviously is one of the biggest topics of discussion in this particular patient. Then what lifestyle changes which might happen after the surgery? Of course, small portions and frequent meals. And the biggest challenge, of course, I feel where as a clinician would be a lifelong aspiration risk. So can actually never be technically supine. So the chance of aspiration will always be high. And then, I mean, as we all know, aspiration pneumonia sometimes is usually one of the most terminal events in a geriatric patient. So the risk is high. Okay, so Dr. Bala, again, since we obviously did talk about various treatment options, so the MDT discussion showed standard options if surgical candidate and standard options without surgical candidate. So if you can get a quick comment on that.
So if she is a surgical candidate, so ideal treatment approach for a adenocarcinoma majority of the times is perioperative chemotherapy, which is a triplet chemotherapy of FLOT majority of the times. So my routine practice is if it is a squamous cell carcinoma, I will try to give and follow the cross protocol, the neoadjuvant chemoradiotherapy. If it is an adenocarcinoma, majority of the times I feel that adenocarcinoma is a systemic disease where systemic recurrences are more common. I tend to give chemotherapy alone. So this is a G junction adenocarcinoma or the lower esophagus adenocarcinoma, which may need not giving chemoradiotherapy is not wrong, but my practice is to give perioperative chemotherapy with FLOT regimen, but it is a very toxic regimen. The docetaxel, oxaliplatin, and 5FU combination is very toxic. So majority of the times, even this chemotherapy can create a lot of problems for the patient. Second thing, if you are not going to give chemotherapy, so concurrent chemoradiotherapy is an option, but completion of all cycles of chemotherapy during RT is problematic because the radiation therapy, the definitive radiation therapy can cause a bit severe mucositis in the patient, impair the nutrition again, and it may also lead to stoppage of the protocol in between also.
Okay, so and Dr. Bala, what are the common side effects which would be seen in these particular chemotherapeutic agents?
So the major chemotherapy side effect we face with the FLOT regimen, if we are going either the FLOT regimen or sometimes if the patient is elderly, not able to tolerate a triplet chemotherapy regimen, we usually give a doublet regimen, that is 5-FU and oxaliplatin. The most problematic thing we worry at this age is because we know that these elderly patients can have a lesser bone marrow reserve. So this chemotherapy can suppress the bone marrow to a greater extent, leading to neutropenias, neutropenic sepsis in some patients. Along that, the docetaxel can cause mucositis along with 5-FU, also causes mucositis, which will impair the intake of the patient. And another most common complication we see routinely is we use a docetaxel, which causes slightly some amount of neuropathy, and we are combining it with oxaliplatin. Already, this patient has a neuropathy component, and this, so it can cause uh, neuropathy. So SAR has message that we can give socks. So definitely socks is a better regimen. So I had a very decent experience of using S1. So I'm actually, if you ask me, I'm a big fan of S1. So S1 we can definitely use, but only the problem is she had already a lot of tablets she's using, and she's crushing and taking those tablets. But crushing and taking chemotherapy tablets can be a problematic thing. So for a patient with dysphagia, swallowing is a difficulty. Majority of the times, I tend to give an IV form of chemotherapy rather than a tablet form. But S1 is quite a good drug, easily tolerable, less side effects.
Okay. Okay, so yeah, we had talked about the supportive measures, whether she's actually a surgical candidate and willing for surgery. Uh, so Suzanne, with all this information, with all the comorbidities, do you feel that she is actually better for neoadjuvant, that is a surgical candidate, or not a surgical candidate?
I think if you go to the next slide, there is something about the frailty, because I think this is yes. Like I said, we discussed this case at the SIOC in a meeting, and the interesting thing I thought was that the surgeon presenting this case didn't think the patient was very frail, but you already mentioned, of course, the multimorbidity and polypharmacy. It was also mentioned that she has dyspnea. So is this heart failure or that she has, of course, or also deconditioning, or is there something else going on? Does she has anemia? We don't know this. The weight loss. These are all red flags, I think, in the somatic department. And then she has a history of anxiety, depression. She's a former smoker. She is fully independent with ADLs, but she does ambulate with a slight limp. So what causes this? This will definitely lead to a higher risk of falls when she's institutionalized or after surgery. Some things we don't know. We don't know the ADLs. We don't know cognition, but she does have vascular risk factors. We don't know if she has a previous delirium. But she might as well have cognitive problems with her comorbidities, and of course she lives alone. So we don't know, like we talked about before, how her network is, but we know that she doesn't have anyone at home to take care of her. And the question is, what is important to her? It says that she enjoys gardening. And I think if you would perform surgery on this patient with high chances of morbidity, afterwards a high risk, I think, of functional decline, then I would say that from that point of view, if gardening is important to her, this would not align with her preferences, but we didn't ask her, of course, specifically. And I think she has a limited life expectancy. Also, if you look at the life expectancy without the tumor, and you would could ask yourself, what's the time to benefit from this surgery with all the recovery time if she would not have major complications after it. So I think there's a high risk of adverse outcomes of surgery, and I would be tempted not to advise against it.
Okay. Have we lost Steve? I think we have lost Steve. Okay. Okay, so when he can reconnect, is he back? Yeah, he's back. Okay, Steve. Yeah. So
Yeah.
with the geriatric considerations which you can see in this current slide. So what, according to you, as a geriatrician, would be the ideal way of going ahead? I mean, now that you have more information, I suppose, yes, there is certain information which is not complete still, but what would be your next priority in this
So
patient?
it's there are a lot of red flags. Okay, so she has exertional dyspnea, which might indicate anemia or heart failure
Yeah.
or probably a chronic lung disease. There is a history of delirium, which suggests that there may be some cognitive impaired reserve, which could be a cognitive impairment or mild dementia too. She's the only positive is she's independent in her ADLs, and she enjoys. There are certain things that she still enjoys. So, given all this, I think we need to have a detailed discussion and explore options of what treatment would they be willing to undergo. Given that if this patient is this still there? Hello?
Yeah,
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 we
yeah.
can hear you.
If
We can hear you. We can hear you.
if subjected to chemotherapy and the even the FLOT regimen, the chances of mucositis and drug-related side effects are not going to be too little. There will be instances that needs careful attention and frequent monitoring and frequent hospital visits also. Given that she stays far away, 45 kilometers, this may mean that she need to relocate closer or need to find a place closer where she can go for regular follow-ups.
Okay.
So there are a lot of negatives, and again, it comes to the question of shared decision making. Discuss the pluses and minuses, and maybe we could try one of the options and see how far we go.
Okay. Okay. So, of course, so what are her preferences? And if preserving independence is her main preference, what would be the most fitting treatment? Because that's what she wants. So yeah, Dr. Bala. So what do you feel? Because she wants preserving of independence, which is pretty high. So how do you? I mean, which would be the best way to go about? I mean, having all this knowledge into hand, because it's her preference is being independent.
Then surgery and the concurrent chemoradiotherapy doses make her dependent on someone because her alone may not tolerate those morbid procedures. So ideal way of preserving her independence, I feel in this case would be just doing a palliative radiotherapy to reduce her dysphagia. And once the dysphagia is bit relieved, when she can able to take the tablet. So ideal chemotherapy regimen, as previously we discussed, a doublet form, the soft regimen, the S1 plus oxaliplatin can be given. Definitely prolongs and give responses and prolongs the life to a certain extent.
Okay, and of course, knowing that she obviously has frailty, uh, and if you see her treatment goals, she obviously is not interested in much of a life extension. It's more of preserving independence, reducing pain, and other symptoms don't
if
really
she's
matter to her.
if she is able to tolerate if she is willing for only not willing for injections also, a single agent S1 is also fine. So yeah, I had seen few patients to have a good dramatic responses with S1, had good quality of life and improved life with even S1, especially for these gastric malignancies and colorectal malignancies.
Okay. Okay, so it comes back to I think the slide that was highlighted earlier by Dr. Suzanne, that the individualized treatment with an integrated oncological decision. So options, of course, we have treatment options. We obviously have the general health status and of course goals and preferences. So all of this matters rather than thinking only of the treatment plan. And of course, an individualized treatment plan is of course something which would matter the most. So actually, what actually happened is something like to highlight. So the patient actually declined surgery. So an 8-month post-cross PET is actually showing mild uptake and increased nodes. And in OGD scopy, new lesion at 24 centimeter. She has been admitted with shortness of breath, malignant pleural effusion, developing worsening heart failure. So I think we are obviously in a state where the only thing that we'll be able to offer is palliation. So in the overall picture, I mean, I'll take a quick comment from all the panelists. First, of course, I mean, continuing with Dr. Bala and then Steve, and then, of course, Dr. Suzanne as well. So, do you feel that her not doing and currently going palliation was one of the better ways for her to do, because it was her decision ultimately, and she ultimately did what she wanted to do rather than maybe what was suggested to her?
I definitely feel so. So what was done was not wrong. So we should
Mm.
respect always the patient's decision, because feeling independent is what she is willing, and we need to do that. And at the same time, even on the oncological perspective, also what we have done may not be completely wrong, because the morbid surgical or the concurrent chemoradiotherapy procedures may have a significant impact on the quality of life of the patient. She might have a fair chance of being crippled and bedridden with those procedures. So
Okay.
I respect her decision, and oncological perspective also, her decision seems right.
Okay. Yeah, Dr. Steve.
So I'm not surprised with this decision because there were a lot of negatives, and if she had chosen any of the other paths, although it may have increased her survival, she will be grossly dependent on others for commuting, for managing her symptoms, for managing her feeding, even managing a cat. She'd be dependent on everything. So it was pretty obvious, and I think this decision was right in every aspect because there are things that she enjoyed, and I mean, yeah. So I think she got to take a decision that mattered most to her, and I think we should respect that. It was really good.
Yeah, yeah. Dr. Suzanne. Yeah.
I think looking back then and looking at her preferences and where remaining independence was by far the most important to her, I think you could wonder if a decision for just palliative radiotherapy might even have been a better decision, because we don't know the 8 months that she was given with the treatment. We don't know the quality of those 8 months, of course, and I think that is important and sometimes, of course, difficult to predict. I think talking about reflecting on what was said earlier about trying a treatment, I think it's also a good time to do advanced care planning, and also to look at expectations and discuss when is a good time to quit a treatment, because that sometimes is really important, difficult. I mean, when you start a treatment, stopping is, in my experience, often more difficult than starting. So I think it's very important to talk about these things beforehand. So I think it's good that she declined surgery. I think it's also always good also to remember that patients with multiple morbidity have also other diseases that they can die from, right? So her heart failure also got worse, maybe also due to treatment, but maybe also due to the natural course of her heart failure. And so I think it's good that she didn't do the surgery, maybe knowing now what we know now, which is always easier than making a decision beforehand before you know how it's gonna go. Maybe even a less intensive treatment would have maybe even be more fitting for her.
Yeah, so Dr. Purvish, sir, your comment.
I think that's a very important point that Suzanne meant at the end, and I also put it in the chat box that I think all the comorbidities put together, even if she wanted surgery, she's not a fit candidate for surgery. So I would very much go on the palliative side. And if at all chemotherapy is to be given, it would be a low dose chemotherapy or a single dose, single agent chemotherapy like S1, and try and keep her as comfortable as possible. Very, very complicated case, a lot of comorbidities and polypharmacy. And I think whoever has treated her has done an exemplary job of making sure that she survives well for as long as she did.
Yeah, I think one of the very important things that here I think was that her will was taken into consideration, and there was no paternalistic sort of decision taken that you should be taking. So I think that is something which was highlighted well. Yeah, I mean, we are well within the time. If anybody has any questions to Susan pertaining to her presentation or regarding the case, you have time, so you can obviously go ahead and ask the participants. Anybody, I mean, if anything that you want to highlight or anything that you want to ask.
I have a question.
Please
Yeah,
go
go
ahead.
ahead.
So when the patient had the malignant pleural effusion, where was she managed? Was she managed at home? Did you have a palliative team coming over, or was she moved to a foster home or managed in the hospital?
I do not have this information, but I think that's also an important question, and also something you can decide on with the patient together, right? How are you going to do the palliative treatment? Is there enough support to do this at home, or should you look for like a hospice, for instance?
Mhm. Yeah. So because that's a huge problem we face in this part of the world. There are a lot
Yeah.
of agencies, but the kind of support you can provide at home is limited due to various factors. The more affordable ones can still manage,
Hmm.
but because insurance does not cover for home related care, and that's a huge thing. The same patient can be treated well at the hospital, even if it's for palliative symptoms, because the insurance covers, but at home this is not covered, and so it's quite challenging then.
Yeah, well, and you can imagine that for this patient, maybe staying at home with a cat would be super important. Yeah. And I was also thinking, what if this patient would have said, my main priority is life extension? That I think that would also have been interesting, right? How to go
Yeah,
about the treatment then.
that would be very interesting and challenging, because with all the comorbidities, I still feel that surgery would have been very, very difficult. It might have actually shortened her life rather than given her a longer life.
Yeah, so I think that's of course important to discuss, and also to ask what the expectations of a patient are with the treatment, because sometimes they have expectations about how their life will be that are unrealistic. Um, but I think what you say, it's of course what we also see from studies, right? That often treating frail patient with less intensive treatment doesn't shorten their life expectancy, but improves their quality of life or reduces toxicity. So yeah, but sometimes this is difficult, of course. If and this also happens, patients they even if you discuss all the negatives of treatment, they still want a chance, want to go for the chance of survival. And this is a minority, but they are still there also here. And I don't know how it's in your part of the world.
Yeah, so I mean, I just want to put it one thing. Maybe was it easier in her case to respect the decision because she didn't have a lot of family members actually complicating things? By that I mean, if you can have children, you can have brothers, sisters. In India, it can happen that everybody has a different view, and
Mm,
a lot of times the patient is not even answering. So they are like, she's either too old or you do everything possible. So maybe the fact that she didn't have a lot of relatives was an advantage in this particular case, where it was easier to navigate. Maybe if she had more, it might not have been a bit more difficult. I mean, that's my opinion.
and just wondering if you have this because that sounds very difficult to me. If you have all these family members and who have different things that they find important, or maybe just want to keep their mother or father as long as possible. We hear that here, of course, also, but the cultural circumstances are different. Um, does it help if you ask relatives, I don't know, about what what's important to a patient, what gives them joy, or what gives them quality of life. Is that something that helps in these sort of decisions? How do you do that?
Yeah, I think, I mean, as far as our conversations goes, yes, we do talk about, I mean, in fact, today in the OPDs, I mean, there was a patient with dementia admitted 4 5 times already for aspiration pneumonia, having a craniotomy, and now on a ventilator, off ventilator. So they are trying to put a tracheostomy and a peg. So I was having a discussion with the daughters that what kind of a, I mean, ultimately, what kind of a quality of life is she going to have with those 2 tubes more? So I think they were quite coherent to the fact that they don't want to give more pain. So I think relatives, if explained to a great extent, are sort of, yes, they understand. But yeah, I mean, there can be various varieties of relatives wherein they have only one goal. They just want that you do whatever possible. Uh, ultimately, I mean, how can you tell me to not do anything for my own mom or dad? So I think that also sometimes comes, that sort of thing comes in their mind. So I
Yeah.
think, is there a question? Yeah, there is a comment by Dr. Joeta saying that the outcome prioritization tool is, yeah, it was pretty interesting tool actually. And uh, yeah, this is which was highlighted by Dr. Purvish also. A lot of times there is people who are not in the same place, so they actually come from abroad, children,
Mm.
and then that becomes, or they are abroad. So coordination, them having some other thought processes, that's not very easy to actually even manage. So I think we are done for the evening. Thanks a lot, Dr. Susan, for your time and for the presentation. Thank you, Dr. Steve and Dr. Bala, for your insights on the case discussion. And thank you, the participants. Thank you for your involvement. We'll be back next month, and have happy holidays and Merry Christmas and a very good New Year soon. Bye bye. Good
Thank you very
night.
much. Bye.
Bye.